Hi, this is Brian Wormers recording a lecture for pediatric nursing and specifically on chronic illness, disability, and end-of-life care. Some of the objectives that we'll talk about will be, of course, chronic illness, disability, and end-of-life care. We'll talk about the child that's got special needs. We'll talk about grief. We'll talk about developmental progression of childhood and the impact of illness or disability upon that. And then we'll talk about end-of-life care and quality of life. So, what terms do we use? And that's part of this slide, is that multiple people use different terms, and it can be things such as medically complex, chronic illness, congenital disability, developmental delayed, developmental disability, disabled, handicapped, impaired, life-limiting illness, technology dependent. So there's lots of different terms. Try and choose whatever the parents do, and oftentimes you just call the patient by their name, which I know is a weird concept, but it's John, it's Joe, it's Jill, it's whoever that patient is. And we sometimes don't necessarily put that special label on them. We do our best to try and normalize this, and basically we integrate them into the population. This is so much different than what it was 50 years ago, which is great, but 50 years ago we'd often put them into an institution and they would very seldom come out and be in public. Now they are enrolled in public schools and in private schools. They're out and about, they have jobs, you see people with special needs out and about the community. So these trends are great. We still need to improve upon them, but we are making strides. So some of the things that we can do with this is family-centered care, of course, and involving the parents, letting them kind of direct our care. Establish those therapeutic relationships where you get to know the family, especially for those patients that frequently need health care. And then, of course, be considerate of culture. Have some shared decision-making power with the family. And then utilize some managed care programs to the best of our abilities. And this can maybe be having a medical home or some other options. So the families of the child with special needs, so a major goal of working with this is to support them in their coping and promote optional functioning, realizing that so much of what we do is working with their families and helping them out. So oftentimes these parents do have chronic sorrow with this. Of course, it's at the initial diagnosis, but sometimes it's lifelong for these kids. Sometimes they hit milestones and markers, and the parents will get sad about and grieve for the loss of that quote-unquote perfect child. When other people their age are starting to graduate high school, go to college, get married, those things can be big stressful events and triggers for chronic sorrow. We have to realize that each member of the family is going to act differently with this. Some of you might know my brother's got Down syndrome, and when they found out, my mom was in the hospital. They found out shortly after birth, and her being the NICU nurse, she had a lot of support from other NICU nurses at that moment, but she broke down and she cried, and it was hard for her to take initially. My dad got real quiet and had to step out and take a walk. And so that they have different coping mechanisms, they have different ways of dealing with the situation, and everybody within the family is going to deal different, work differently with this. So some major themes. So this kind of resembles some of the grieving cycle that you've learned about in psychology and stuff like that. But first, there might be some shock and denial. Are you sure? Is this lab test accurate? Or, is this really going on? Then there's some adjustment with this, where they're like, okay, well, we got to change this and this and this. And then hopefully we develop towards more of a reintegration and acknowledgement standpoint. And so realize that these different stages can kind of wax and wane, and you can go between being adjusted to back down to shock and denial to reintegration and then back down, and it's going to kind of wax and wane throughout the period of this child's life. Impact on development. So of course this is going to impact development. Ultimately our goal is to help them to achieve the highest maximum potential and help them out as much as possible. So oftentimes these children are receiving multiple assistance in school, and PT and OT, and lots of socialization. Doing so is trying to get to that optimal level of care. Once again, developmental stage directs where we're at with these patients. They might be 35, but they're going to act like a 6-year-old, so we treat them like a 6-year-old. We work on that developmental level. So if we talk about those, review and look through those different developmental stages and how are we going to treat those children at these different developmental stages. Things when they're growing up, and especially as we're talking about anticipatory guidance, we need to start thinking about what to tell those parents. What are the next stages? And then remember that they develop through these different stages. So when we're doing this teaching, we have to talk about the next things that they're going to encounter. And so we do have to worry about activities of daily living, and as they get older, what can they do? Can they feed themselves, and how can we best support that? Do they go to the bathroom on themselves? Do they ambulate? Do they participate in sports? Safe transportation can be a major issue, especially as kids get older. When they're young, we put them in a car seat, and that goes pretty quickly. But what happens when they're 35 and they weigh 200 pounds or 300 pounds? And what's that going to look like for safe transportation for them? What happens if they get a wheelchair? What happens if they've got walkers? Those type of issues. So safe transportation is a concern with this. With impact on development, we also have to think about some of those hard conversations that maybe we didn't think about before. As they're going through those stages, especially as we start talking about adolescence, they still can fully develop in a sexual way. So we do have to talk about sex, what's inappropriate, what's appropriate. We have to talk about drugs. We have to talk about tobacco. We have to talk about alcohol. My brother, when he was 18, he got solicited from some of the kids in high school that, hey, now you're 18, can you buy us cigarettes? Can you buy us lottery tickets? When he turned 21, they hit him up for alcohol. And so that can kind of happen, and these kids can get manipulated, for buying those limited things, or even manipulated for sex or abused those kind of ways. So, end-of-life care. So this is a lot of things to consider. There's no real right or wrongs with this one. Consider those developmental stages, and how are we going to work with those kids. Oftentimes the kids know more than what we ever give them credit for. They tend to know about the end of life is coming. Biggest question I probably heard is it going to hurt? I can't answer that one. I haven't died. But I do know that we can give medications. We can give medications for secretions. We can give pain meds. We can give multiple different things to try and make that journey a little bit easier on them. Big questions include who makes the decisions. We used to be very paternalistic with this. Providers made all the decisions. What we're trying to do now is be more holistic and what are the wants of that family. Some of the decisions that do need to be made is, palliative care. This should start early on. This is for maximizing life, not just end of life cares. So palliative care can be anything with increased morbidity, mortality, or kind of a chronic nature. We have to talk about window withdrawal care. What kind of cares will we provide? If we're talking about mortality and death, then do they want to have the child die at home or die in the hospital? Arguments for both are extremely valuable or personal, and both are correct. Some people are, I want the child to die at home, or we can surround them with family and loved ones and to be in a nice, warm, caring environment instead of the sterile hospital environment. Other people are like, I could never walk into that room again. It would be so tough. I don't know what I'm doing. I'm afraid of things might happen. I'm not sure if I can handle this. I want you guys to help me take care of this. and help me at this time. So there's not a right or wrong, it's just whatever they want. Donation may be an option. Remember that with donation we are a little short on child-sized organs, and so donation might be an option, and that's can be very reassuring for the family sometimes if somebody else is able to gain from this sad time. After death care, be with that family if they want. Let them have the amount of time. I've seen both spectrums of this where the child dies and to them the spirit's gone, baby's no longer there. They put the child up on a shelf and walked out of the room, which that's their thing. I've also seen it where they rock and hold them for hours after the child dies, and once again that's their belief. So just assist them, help them out throughout this during end of life type of thing. Play some soft music. Maybe we can silence all the monitors. Maybe we can even dim the monitors so you can't see them in the room. Just see what they want. See if there's any special preparations we have to make according to culture. Are there any special outfits that they need to wear, clothes that they need to wear with this? Do they need to be facing a certain way? Is there any religious items that they want to have? So all those type of things. Also have to talk about care for the nurse. When you're caring for these situations, it's alright to shed a tear. It's alright to be sad. Show that you're human. If you don't ever cry, you don't ever get sad, you don't ever get emotional with your day-to-day job, and you're dealing with these very sad situations, it might be time for you to leave. There is a boundary though. If the family starts taking care of you more than you're caring for them, maybe you've crossed that line. And then of course afterwards you need to find some kind of release, and whether that's talking to your dog, who is your best therapist ever, or going for walks, or exercising, or talking to other nurses, or going to a real therapist. Whatever you need to do, you do have to take care of yourself. Alright, and finally we do talk about grief. Grief with those end-of-life cares and with families. Big considerations of this is that know that grief changes with time. It probably doesn't fully go away. If you lose a loved one, you're always going to remember that loved one. It's not like it just magically vanishes and everything's better. They do go through those stages, but remember it's not always going to be in a linear way. They might go forward, they might go backward. It's going to change with time, seasons, environment. Sometimes holidays, of course, can trigger some things and cause memories. And there's no time frame for this. So if somebody is like, oh, it's been 6 months, you should be over this, that's not true. Everybody grieves a little differently. Some people are very loud, some people are crying a lot, some people are very stoic and quiet. But just support them with where they're at, and try and help them work through the process. But just realize that the process will be different for everybody. Alright, so this being said, if you have any questions on this slide, please contact your instructor, and hope you have a great day.